Please welcome to the stage Marielle Concepcion, MD, owner and CEO, Big Trees MD.
So now we're going to go into our second set of sessions. And in this session, we are going to continue talking about how we change healthcare under the DPC umbrella. And when we talk about changing healthcare, we are going to be talking about the fundamentals of healthcare, how we practice with our own personal biases, and how we practice authentically. So with that, we'll get started in our next set of sessions. Enjoy.
It looks like people are coming back from break. So I'm Dr. Julie Gunther. We have about a 25-minute panel right now to talk about money, which did not used to be one of my favorite subjects, but now it is. It's one of my favorite subjects to talk about because I think there's so much money in healthcare. The only way we're truly going to transform healthcare is by having authentic conversations about where money comes from, where it's going, and who it's getting distributed to. And the cool thing about healthcare is there's so much financial waste that I firmly believe we can all win. Patients can win, physicians can win, providers can win, insurance plans can win, employers can win. It's so bloated and so inefficient, there's nothing but opportunity. So these lovely gentlemen are going to, I'm gonna ask them some tough questions, hopefully. I'd like to save about 3 minutes or 5 minutes to try to open questions up to the audience. I did not prepare slides, well I did, but I didn't post them. If you go to my LinkedIn, there's something I'd like you to look at. So I'm Julie K. Gunther, it's a black and white picture. I linked I put a link into an article written 5-6 years ago by a physician that demonstrated, and there's a graph. If you scroll down, you'll see like an Excel spreadsheet, and then you'll see a graph. And if you look at that graph, and what I like about giving you the actual article is you can take time to read it and kind of let your mind explode, and then it also has proper attribution to Dr. Kevin. So that graph demonstrates that when I graduated high school, and I'll pick on Brandon. Dr. Brandon graduated high school, but right now Dr. Brandon's not a doctor. So when I graduated high school and Brandon graduated high school, I began the journey to become a physician. Dr. Brandon took a job right away as a UPS driver. How long do you think it is if we add up the total amount of money made year over year? How long does it take a doctor, a primary care doctor, to catch up? This is not with investing or anything. This is just, he starts making money straight out of high school. I start making money when I finish residency, basically, or residency. And if you look at that graph, it's where the red and I think the brown line intersect. The answer is 17 years. If that UPS driver works overtime, equivalent to physician's hours, so they make overtime pay, it's 27 years. And if that UPS, did I say UPS physician? Anyway, if that UPS person invests that money at a marginal interest rate, and I do the same thing, it's 60 years until I catch up. So one of my passion projects right now is changing the conversation about healthcare innovation to say, if we're going to innovate, we need to innovate the whole thing. And there's an area where there's tremendous opportunity for innovation is not only in how much we pay physicians, but how we pay and how we contract with physicians. So Jeff, go ahead and introduce yourself, if you will, and then will you give us a 2 or 3 sentence explanation of how you and or your business entity is innovating on behalf of physician compensation?
Sure. So Jeff Bernhard, 20 years with that, the last 2 years, one of the presidents, one of the group, Highmark in the East Coast, now CEO of Revive. So what Revive is doing to innovate, really 2 things, I would say. Number one, it's been talked about already. Myself, with an addition of 2 or 3 other executives from United, Cigna, and Aetna have come together to drive a large self-funded plan sponsors into a hybrid model of virtual care and DPC. So I'll meet with you, some of you later in the evening, but we want to partner with people like Julie, Jeff, and others to make sure we drive large customers. We're talking 10,000, 20,000, et cetera, and leverage our relationship. So number one is driving volume through, and number 2 is we offer a virtual subscription-based membership, which in working with DPCs does not add any additional costs. So we don't do claims, we don't ask for authorizations or any of that. We send members to you, we allow you to do what you do best, But our interest is to drive thousands and thousands of people to you across all 50 states. And in fact, I do work with Mr. Contorno over here to the left as one of the brokers of his networks in doing that. But it's good to be here.
Awesome. So for full transparency, I started providing some consultation services for Revive in the fall, and came in kind of like a heat-seeking missile and fully expected them to be like, get this lady out of here, because I'm super passionate about defending the integrity of a physician's job and the physician's role, and have been just ecstatically delighted that we are having more and more people all across the healthcare spectrum start to understand the integrity of what we do, and want physicians and want to allow us to maintain autonomy and want to allow us to potentially have more, ability to plan for our own business. So Dr. Brandon from Antioch Med, amazingly successful DPC practice in Kansas. Well, you can introduce yourself as well, or what are your thoughts?
Yeah, so quick introduction. I'm a director of primary care in Wichita, Kansas. We have grown to be 5 physicians, and I think your kind of original question is how are we changing the physician structure? I think being close to residency, so we actually opened our clinic as I was starting my 3rd year of residency, so have not been ever in the fee-for-service world. So I joke that I have no original sin. I think what I see being close to a residency is that, especially in family medicine, people are trained very broadly, and then they're thrown into a market that can't use their services because they're either thrown in, we want you to see 30 patients outpatient only, and we're going to pay you X salary, even though they've been trained to do inpatient medicine and do OB and do all these things. And so in our practice, we're a little bit unique in that we're trying to bring that back. And by growing, that's going to allow us to hire on physicians to jump right into a role like that and not make them go through the 3 years of building a practice like I and Dr. Thompson had to do when we started our practice. So.
And since you have no original sin, I'll come back to that. Dave Contorno, can you tell everybody kind of where your space is and what you think about how physicians are compensated and how we could innovate?
Yeah, so that's loud, sorry. So I build health plans for employers, and we have employers of 9 employees is the smallest, and we've worked on plans that are into 7-figure employees and everything in between. For this context, what I want to say I do is I build health plans for employers that have a function to interact with the traditional healthcare system because you have to have that there, but heavily prioritizes, incentivizes, and educates care to be consumed by providers like most of you are here, whether it's a primary care physician or an ambulatory surgical center or an independent imaging center or an independent pharmacy. I mean, I would put primary care physicians and pharmacists in the bucket of I'm not doing much of what I went to school for if I'm a traditional pharmacist or doctor. I say to my pharmacist all the time, I'm so sorry you went to all this school and now you just take pills out of big bottles and put them into small bottles. But what's really miraculous is the patient satisfaction. The end result when we build plans around DPC, and to my knowledge, we've been doing it the longest. We started it with Dr. Shane Purcell in Anderson County 7 or 8 years ago, where the DPC is not just the center of the care for that patient, but also the center of the plan, the health plan for that patient. It doesn't mean they're filling out HCFA forms, and it doesn't mean they're submitting for pre-cert. As a matter of fact, we eliminate those 100%, not 99%, 100%. But it's giving them the ability to help direct the care for that patient even when they feel clinically it's appropriate for them to go to maybe a fee-for-service specialist. So we've done plans with Brandon, we've done plans with a lot of doctors in here, but I will tell you the biggest testament is last week we closed 5 new employers, and 3 of those employers were referred to us by physicians. So they are helping us build these plans, helping us build their membership, helping us support these alternative payment models in ways that fundamentally dramatically improve outcome, patient satisfaction, and lower costs substantially.
Awesome. So how many people in the room right now are physicians, NPs, or PAs? You raise your hand. Awesome, so the majority of you. Okay, so you don't look. How many of you that just raised your hand would say a former Aetna CEO and a broker feel like the boogeyman under the bed? Not too many, actually. You guys are like not super traumatized, then that's exciting. I would say when I first launched my DPC, I just really I never wanted to hear the word incentivized again. That word bothered me. And I really didn't care what my pay was as long as no one was pulling any strings. So Dr. Brandon, if you could create your most perfect pay contract, if you could design how every physician in the US should be paid, and I don't like the word should, but what 5 things or so would it have? What would it look like? And I'm hitting them up. They're like, I sent them questions. I'm totally not even following my questions. So these are amazing minds. They can handle it.
Yeah, I think the word incentive doesn't have to be a scary word. I think it is used as a tool against doctors a lot of times. We're going to put you on some incentive-based thing, and really that means you're never going to meet it, and we're going to pay you less. But like when David says, hey, we're changing the way healthcare is paid for, what that allows is for incentive to be aligned. Because when he says we're making the center of the plan, or the center of the plan DPC, what I hear is, hey, I get to innovate and build a medical home for people, and that's going to allow them to get better care, be healthier, and not cost anybody more. So example of that, we just saw that mental health was a huge need for us. And so we just brought on a mental health person in October, totally cash pay, and she's full after 4 months. And so like a little bit what you're saying, like how do I get paid? Well, pay me for how much value I'm providing. And right now, most DPC, that is, I decide it takes me this much time to care for a patient, and that translates into a monthly fee to our clinic. So to me, that's the structure that has worked for most DPCs. And you can set that regionally and for kind of how much you're offering as well.
So if you were going to hire me right now, what would you offer me? Not necessarily number, terms. 5 things. What terms?
Are you talking to me or the whole panel?
You.
Yeah. So
I'm gonna move to Kansas.
I'm recruiting two residents right now. Hopefully they're watching this. What we want to get to by that is we have a competitive salary for you that looks like what you would get if you went to one of the big hospital systems and they hired you as a primary care. Except now when you see a patient, it's not 7 minutes. It's you're solving this patient's medical problems. And so the numbers look similar, but the job description is now, hey, do what's best for the patient, and all the downstream things are going to work out. Whereas most people have left fee-for-service. I hate the word burnout, so I think the proper term is like moral injury, which is a Z-dogism. The number doesn't matter as much as morally when I go home at night, have I done the right things for my patient? And you know better than this, that doesn't often happen in the fee-for-service world. So.
Okay. So, and I'll fill in the blanks with my opinions if I want, but Jeff, do you and I had an interesting conversation about, I would call the challenge of 500, right? So I grew as a micro practice, this sort of like Dr. Benson's practice yesterday, this beautiful little hometown practice, word of mouth marketing, onesie twosies growth, right? And for me, that's created an incredible business tension point. So the challenge of the 500, you and I've kind of talked about 2 different types of DPC 500. Will you comment on that?
Yeah, so, I think to really move the needle, what our focus is going to groups that have over 500 employees and then providing a monthly reimbursement to the DPC for that. What I've learned after talking to Julie and Jeff and others is that one of the biggest challenges that DPC offices have is cash flow and getting cash flow from large employers. And I'm here to tell you, I've spent the last 20 years at least dealing with the largest companies in America. Time's up. Time's up for the carriers. They're looking for something different. David could tell you this. And what we're looking to do is go to that employer of 1,000, and we're looking to charge X amount and pay Julie as a DPC for all 1,000 people. And the difference is that you're going to get X amount for all 1,000 people. But a patient is not really a patient. So when you have 500 individual patients that sign up with you individually, they're doing that for a reason. There's selection there. You have 500 patients, 500 enrolled. If you go to an employer that's got 1,000 lives, you're going to see 150 people a month, regardless of what you do. We can market to them all they want. They've got young invincibles. They've got people that aren't going to change their doctors. But what you will do, and I want to say something that what Brandon talked about, I am more convinced than ever that carriers, which I've been part of for a long, long time, they've had 30 years with the system to get people with chronic conditions under control. Time's up. It'll never work when you have 10 minutes with a patient that's got multiple comorbidities. So what we are doing is going to large employers. We're guaranteeing with the study that you've seen, and we think we'll give a 3-to-1 ROI. The only way that patients get better is to spend time with you as a doctor for 30 minutes and having us support you in every way possible with data and so forth. They need time, and the system doesn't support that. So you have what we have in the United States right now. So I do think the system can work. I will tell you, employers that we spoke to are ready to talk, as David knows. And what we're looking to do is go directly, as was said by our earlier guest, to employers, sign a direct contract. And to Kenneth's point earlier, we have found a way around the HSA high deductible. So we have found a way from the ACA and ERISA to make it work. But we'll talk later, but lots of changes are happening. Now is the time, and employers are ready.
So one of my passion statements, as we were sort of talking about what this, I like to call Revive a bridge. There are other businesses out there that are sort of like Revive, and I'm really excited to see what's bubbling up. I think has a lot of integrity, and we're seeing more and more people across industry really understand and really be invested in wanting to make change. So I think the absolute most important part of physician contracting is autonomy. So not just time, but I'm in charge of that time, and I get to call when that 30 minutes needs to be 60, when that patient needs 3 visits, when that phone call needs to turn into a face-to-face. A very important matter for DPC physicians, right? As many of us are opted out, and that hamstrings a lot of our opportunities. So people who are innovating, who want to work directly with DPC physicians, need to think about the need for working with Medicare opted out physicians. So I'll kind of put that sampler, but autonomy is my number one, but basically hands off, let me do my work. And that is actually, I think, the overarching value above what the numbers are. But the numbers have to have integrity. So Dave, in terms of what you do, what have you seen? You and I know Dr. Purcell very well. Dr. Purcell is a happy, passionate physician. So the physicians that you work with who are happy, what do you think are the terms of how they work that make them happy?
I mean, you really touched on it. It's not putting them back into some sort of volume-based game that they were in before. But at the same time, we need direct primary care physicians to not be so hands-off that they are just an employer paying $50 per member per month additional on top of their Blue Cross and Blue Shield plan. That really doesn't change the curve. Members can still go right to their back surgeon without a referral. But it's really working with the providers that want to manage that care. I mean, one of the expectations we set with the DPCs that we build into our plans is that when they do refer a patient to a specialist, they don't just refer them out and then wait for them to come back, that they are communicating with that specialist on a regular basis. They're not only filling in gaps in whatever clinical records the patient could or couldn't remember, but they're almost being a voice of a second opinion. And then most importantly, they are bringing that patient back under the care of them, of the DPC home, as soon as clinically appropriate, instead of letting the traditional healthcare system do that. And you know, I remember being at this conference in 2018. I think it was the second year of the conference, the first time I was here, and it felt like this was a fringe group. It felt like this was something that was so small, wasn't making an impact. Other doctors didn't know about it. And to think that we're here 4 years later, and not only is this becoming incredibly well known throughout the clinical community, but it is becoming well known among the patient community. And when we first started, the first plan we did with Shane Purcell, we offered 2 plan options, as I mentioned, a DPC kind of gated HMO style from a member perspective, and then a go see any provider you want. And we had about 25% choose the DPC. Today, we generally range between 40 and 60 year one, and it goes up every year. But we had our best success at a private school outside of Chicago, where we had every single employee except for one choose the direct primary care plan. And it's often, even though many of you guys are underpaid or have been underpaid, I just want to level set for a minute where America is at, because it's different than I would be willing to bet practically everybody in this room. But I was rolling out a DPC plan to a client outside of Chicago a few months ago. And the first thing I said is, how many people in this room have a relationship with a primary care physician? And only about half the room raised their hands. And this was a blue-collar physical group. And then I said, okay, keep your hand up if over the last year you've collectively spent more than 8 or 9 minutes with that primary care physician you claim to have a relationship with. Because let's face it, if you're spending 10 minutes a year or less, it's not much of a relationship. But I asked them this question, and this was the most impactful. I said, how many of you have gone into that primary care physician for, let's say, your annual physical, your wellness exam? And what happens? You get there, you wait an hour in a sick waiting room, you finally get brought back to the exam room, and 20 minutes after that, finally someone walks in. Who is it? Not your doctor. It's a PA or an NP, and they ask why you're there, and they draw the blood work, and they send it to the lab, and then the results come back, and now it's an hour and a half past your appointment time, and finally the doctor comes in and says, okay, you need to lose weight, and you need to stop smoking. Is there anything else you want to talk about? I asked this group, how many of you have thought to yourselves, I've had this rash or this headache that keeps coming every couple of days, but I know that if I bring this up to my doctor, this visit is going to go from no cost to some cost, whether it's a copay or even worse, an HSA compatible plan where you don't know the cost and you have to pay the full amount. How many of you have not expressed that to your doctor because of that very thing? And a very large percentage of the room raised their hands. So let me just clarify this. In the 6 or 7 minutes that most of America does get with their primary care physician, they're often too afraid to tell them their medical conditions because they're afraid of the cost. Meanwhile, the doctor's suffering and miserable, the patient's not getting good care. So there's a huge demand, there's an upswell coming, I think, from the patient community, especially as it becomes more broadly known and heard about, and other people find out about it.
And to that point, we've created a social narrative where what I do for you is free, right? Well, I can see my doctor for free. So I think we're almost at time. To me, to people who are looking at innovating, I think expressing what I see among my physician culture as values, it's don't pay me for what I do, pay me for who I am, and let me be that thing. So paying me in an incidental amount, chipping away, negotiating an extra $2 here if I do it right. You wouldn't hire an employee and then be like, not 100% sure you're good at this, but if you are and you show, I'll give you a little more. Or maybe some people do. But I was told, trust people, recognize their expertise, pay them equivalent to it, and let them fly. So when we're thinking about, and my other favorite recommendation is anyone around a physician who says just needs to leave the room. Well, you just need to click this. You just need to write this down. You just need to log in here. You just need to do one more thing. That just word means, oh, I think there's one more thing we can put in the physician's bucket. Because for every just, it usually means I'm actually not being what I am, which is providing care. So I don't know if we have time for 2 or 3 questions. Anyone, or if we need to be done. We are all here today. We're available. I don't see any. Is there anyone official? All right, we'll take 1 or 2 questions. Does anyone have a question or an idea? I see. Yes. I'll repeat your question yeah. I can, and I'll repeat it. So that's a super good point. So her question / comment was that the 500 versus 1,000, and Jeff and I've talked about this, saying that when we say, and I'm not going to represent what you said very well, but we all know that we're good. And so when we hear, oh, there's 1,000 people who will have access to you, but only 150 will utilize, that's often not our experience, especially if you piggyback that on this, well, I've been growing word of mouth grassroots, and if these people are excited, their friends get excited. So the 500 concept is this. There's sort of a split in DPC business models. And they all have different points of tension, and my strong opinion is I wouldn't lean your full business on either one. But if you grow incidentally, if you grow word of mouth onesie twosies, it's slower and you're safer. And Dr. Gold kind of referred to this, because you're not going to lose all 500 at once, right? Because they're not a single entity. They're all different people. But they are joining with intent to use. So the vast majority of those people are joining, and they are higher utilizers, right? So you have incremental join with incremental dollars, which is very different than having a larger employer group that you're paid a smaller amount for each person in a longer duration, usually a 2 or 3 year contract versus month to month, right? And you have some accountability, whether it's just a telemedicine structure like happens with MyMD Connect, or whether it's a telemedicine structure and these people can pivot and join your practice. All of this works if the numbers are right? Because if I told you, well, I don't want to throw it real, but so if I told you, you're going to be a telemedicine doctor for these employees, when they call you, I'll pay you $19 for a 15-minute visit. I mean, yeah, you can do 4 of those an hour, so now you're making $80 an hour. And I write there, I'm like, that breaks down everywhere, every way. Well, we'll pay you a little more if you do the charting right. And I'm like, this is all not how this works. But what if I said, if you have a 1,000 employer group, I'm gonna pay you $14,000 a month for 3 years. And if the utilization goes above anticipated, so we think utilization should be 15%, that's supported by data in traditional healthcare structure. I 100% agree with you. Utilization is gonna be higher because they're all gonna talk, right? So when utilization goes up, compensation goes up. And that changes DPC because if someone came to me today and said, for the next 3 years, you're gonna have $10,000 a month, I can hire a physician. I can hire one of you and say, here's the salary I can pay, right? But I can't do that if I'm growing one at a time because I have to bloat my practice and carry the burden of the higher volume than I wanted, and all of a sudden I'm back in the fee-for-service structure. Does that make sense? So it's just kind of, there's all different ways to do this. Some people partner solely with employers. Some people have a little bit of both. I like a little bit of both as a business idea. There was one more hand. Yes?
Julie, I think that you answered it just as I was thinking of it.
Say that again?
You answered my question just as I was thinking of it.
Okay.
And that is, because I was going to say, how do you pitch the idea of an employer picking up the tab for direct primary care provider when 20 to 30% of their people traditionally are going to use it and the rest they don't. They don't see what the value is. But you're talking about kind of a sliding scale, a utilization scale.
Right.
So
So the cost in aggregate to the employer is lower.
I can give some specifics around the finances of it.
Good. Yeah. I didn't know where the voice was. You sound like Jeff Gold. I was like, where's Jeff Gold coming from?
You know, my wife told me today I look like Jeff Gold, so I've gotten two aspects. When we take over a plan and then we put in direct primary care, and if we have access to data, we don't always, but when we do, and we look at what the primary care spend was for that population before versus what just the membership fees are going to be going forward, we typically see somewhere between a 300% and 400% increase in primary care spend. And when you say that to an employer, they're like, whoa, I can't increase costs. But what we also have data to show them is that we see a 50% reduction in inpatient admissions, a 50% reduction in outpatient admissions, a 70 to 80% reduction in specialty medications, a 90% reduction in specialty referrals. And those are all way, way, way bigger buckets. We're literally taking their smallest bucket and increasing it this much to take these much bigger buckets and decrease it substantially. But the challenge is, you can't tack on a DPC membership to a Blue Cross and Blue Shield plan because you don't create the steerage necessary to present that patient to the DPC at almost every turn. And I know I was doing an open enrollment today with, I believe Kendrick Johnson is here, but his PA was here doing the meeting. And they were asking all sorts of questions around this very same thing. And what we have to explain to them how the improvement in clinical state, the time that the doctor gets to spend with the patient, how we're not just treating symptoms anymore. I mean, that's what most of the healthcare system does, is they attack the symptoms. But as a general practitioner, as a family physician, your real goal is to diagnose the problem and to address the underlying cause of those symptoms. And that's a fundamentally different approach that results in people getting off the medications like Humira that they thought they were going to be on for the rest of their lives, or getting them off the metformin when they have type 2 diabetes. I mean, these are things, and I myself have been, when I went to direct primary care, and part of the reason why I'm so passionate about this is that I was type 2 diabetic 15 years ago, and when I found the right doctor finally, I'm not diabetic at all anymore. It wasn't just throwing metformin at me, it was curing the underlying
Good job
disease.
to your doctor too, but
Thank you. So that's why I'm so passionate
you worked
about
it out. So I want to be respectful of whoever's next. Oh, is that Dino? Hi, Dino. Do we have time for another question? I want to be respectful. Okay, go for it, Dino. And then after this question, I'll just have you guys each give like 1 or 2 sentence final thoughts.
So my question is, when it comes down to measuring utilization for the purpose of reimbursement, what are the nuances around measuring that so that it doesn't end up looking like fee for utilization?
Are you talking about accounting for utilization when they're in the DPC model?
Yes.
It really depends on the history of the employer and the employee population. One of the best case studies we have is an employer that has been a client of mine for years, and we had a non-DPC plan, but otherwise all the things that we do. And then we're launching DPC in certain geographic markets. So we just launched it April 1st in the Chicago area. And that allows me to compare the same population to the same population, because I don't want to put the DPC in having to check all those boxes to give me that data. It's not fair for them. It's not what I want them to be spending their time on. So instead, the only time I can really compare it is when they were in a plan that had full transparency and then added DPC. But most of our clients are going into a transparent health plan and adding DPC at the same time. So then I have to look at it, more globally. What was the specialist cost, the outpatient cost, the inpatient cost, the medication costs? And then for the population that did choose the DPC, how does that compare? But I will tell you, I've never asked a direct primary care doctor to check boxes, to cross T's, to dot I's in notating that. I want that time spent with patients, not on paperwork.
Well, and that's a perfect segue, and I actually want to see what Jeff has to say about this. But there's awesome billing platforms like Hint that can track touch points, right? So that's a good question. What's a touch? What's an encounter? Because we all know what you'll get into is, that was only a call, Dr. Gunther, so that we actually redefined it, that they're not really a patient of yours. In the spirit for me, well, I'll turn this over to Jeff. So to the question of how would we, if a physician were to sign on and had a tiered compensation plan that was a monthly retainer for 3 years and utilization went cuckoo because they're amazing, how do we have integrity around that? What counts as utilizing?
So, I mean, there's numerous touch points. We'll measure telehealth visits, we'll measure in-person visits, we'll measure urgent care visits. I think if
does tech measure that, or does the physician attest that?
No, we would measure it for them. So you don't have to keep track. And then we would build it into the employer contract that basically said once utilization gets over a certain point, especially for the in-person, then the employer, the self-funded employer, would ratchet up the amount that they pay you. And, maybe that's a good thing. Even still, there's still going to be people that aren't going to come in a large group. They're just not. We'd like to get as many people in as possible, but I've been doing this for a long time. It's hard to get people there. I think you can get them there with telehealth. I just wanted to say, because I know we have to get off stage, the closing comments. So you may be saying, well, where are all these people going to come from that you're approaching in these large employers? Just think about something. There's about 125, 130 million Americans that are insured through employer plans, through large companies, that I would call functionally uninsured. So they have insurance through Blue Cross, Aetna, Cigna, United, but their deductible is too high that they cannot use it. They can't use it. And they don't go anywhere based on what David said, which is, they're afraid they're going to get billed and so forth. So what we do is we tuck in underneath that deductible, and we can do it for an HSA plan, and we partner with the DPCs to make sure that we get people to you that need to be there. Now, they still have the homeowner policy, known as major medical. If things go really bad with hospital cancer, those type of things, you can refer them in. But the everyday care, you can operate at the top of your license, and they can get it very affordably. 125 to 130 functionally uninsured.
Yeah, and to that end, another way to think about these employed models, some people do already have a physician and they want to stay in the traditional construct. So this is an add-on opportunity as designed in this discussion. What do you think, Dr. Brandon?
Yeah, I was just going to share my one closing thought. So you asked the question, do you think a broker and a former carrier exec are evil? And there were still some hands. And if you asked me 6 years ago, I would have answered yes. But I think my closing thought to the physicians out there, whether you're starting or growing or whatever, is that if you want a lifestyle practice, that's awesome, more power to you. If you want to change healthcare, you got to find the right partners, and don't be as scared of finding the right partners if you're a physician out there. So that's kind of my closing thought.
And I'm going to leave you guys with a closing thought. I've spoken with hundreds, maybe thousands of employers on direct primary care. We've set up direct primary care at dozens and dozens of employers using maybe 100 different DPC practices. I'm going to let you know one question that an employer has never, ever asked me. How much is that membership fee, and can we get it to be less? I've never been asked that. It's irrelevant to them at that point. If it's sold right and it's educated properly, the membership's irrelevant because they know they're getting an ROI. And I'd almost argue the higher the membership fee, the better the ROI they're going to get. So I know when you're dealing with patients directly, and a lot of you come from either only that space or that was the space you started in when you went to a DPC model. But in the employer market, when it's sold right, that's not the issue. And so you can get 20, 30, 50 patients at a time, charge a reasonable fee, and not even have to worry about negotiating or putting pressure on that patient directly financially.
Yeah. Awesome. Thank you, all three of you. If you're new, your head is probably exploding. So I have a counselor who tells me, Dr. Julie, don't eat the whole pizza at once, one slice at a time. But what I also know, I'm 8 years in, and you're entering entrepreneurship, your landscape is going to change. So this is the sampler of all kinds of wonderful things that are happening and creating opportunity for transformation. And tons of people are at the table now, from people in tech to accounting to telehealth, insurance executives with an incredibly amazing understanding of big business and the conversation. And someday we will have the full pure solution, but right now we're changing things across the board. And the more people that come to the table with integrity, the better this whole thing looks. So thank you so much. Thank you for the time. Thanks, Hint, for letting us go over a little bit.